Hello, I'm David Gordon-Koch, reporting for the NB Media Co-op. With an election coming up later this year, the privatization of healthcare services is under scrutiny in New Brunswick. Companies that provide temporary nursing services have been especially controversial. Last month, the Globe and Mail reported that public spending on private nursing has skyrocketed since the start of the pandemic. One of those companies, Canada Health Labs, reportedly charged fees amounting to roughly $300 per hour, or roughly 6 times what a nurse on staff at a hospital in Atlantic Canada typically earns. New Brunswick's Vitalité Health Network was that company's biggest client. The leaders of the provincial Green and Liberal parties have spoken out about the issue while holding consultations on healthcare across the province. At a public forum in Moncton held by Green Party leader David Kuhn, the threat of healthcare privatization was a theme. Kuhn criticized successive governments, both Liberal and Conservative, for the privatization of healthcare services. He said that privatization is accelerating at an incredible pace.
It seems like every time you turn around, you see another part of healthcare management being privatized. So we've got extramural, Brunswick went to Menifee Blue Cross. MB HealthLink, which is the new waiting list that is designed to give you access to primary health care while you're on the waiting list, it went to Menifee HealthLink. Menifee Blue Cross. 811 is run by a private company. We've got eVisit New Brunswick, which is run by Maple. We've got travel nurses now who are managed by and delivered by private companies. This is causing a significant increase in the costs for delivering healthcare. It's creating more silos, so the kind of seamlessness of our healthcare system that we really need for it all to work is being broken up and fragmented by the privatized management of all of these services.
With chronic problems in the healthcare system, such as long wait times, Premier Blaine Higgs has stated that all options are on the table, including more privatization. And in a phone interview with the NB Media Co-op, Minister of Health Bruce Fitch defended the private delivery of services. He noted that many doctors already operate as small private businesses, and also pointed to corporations such as Johnson & Johnson and other big pharma companies that are already part of the overall health system. But there are long-standing concerns from organized labor and other groups that more private delivery of services will actually make the system worse. But not according to the Minister of Health. He pointed to a private physician-operated surgical clinic in Bathurst. Here's what he said.
Is one of the prime examples of where a private enterprise has alleviated backlogs and wait times is our cataract surgery projects. And we started that in Bathurst, and I think the results, which were published by Vitalité not too long ago, was stunning, where the wait for cataract surgeries in the Acadia Bathurst zone was at 1,465, waiting more than a year. And now that has dropped to 268 patients waiting more than a year in that Bathurst Acadia zone. So there's an example where, again, private enterprise with the advancement of technology and has gotten to the point where they can take those procedures out of the hospitals, put them in a private clinic. And the key is those procedures are being paid for by Medicare, and it has impacted the system in a very positive manner.
But as reported by the CBC, even the doctor who runs that clinic in Bathurst has warned about corporations focused on profits gaining a bigger foothold in the healthcare system. Concerns about profit-hungry companies delivering healthcare services aren't limited to New Brunswick. Critics from across the country argue that private companies will draw health professionals away from the public system, leaving it more understaffed.
I asked one of the nurses, I said, where did you come from? Because that argument about, oh, we're going to drain the public system. And she said, I was going to retire. I had had enough, but I'm going to extend my retirement and work here with the doctor, because it's a nice way to prevent my retirement. So it also is now providing an opportunity for people to extend their career.
Meanwhile, Liberal leader Susan Holt says that her party is not in support of healthcare privatization and that privatization would not expand under a Liberal government. In 2017, the government of Liberal Premier Brian Gallant handed over management of extramural and telecare services to Medavie Blue Cross. That company has also run the provincial ambulance service since 2007. Critics say it lacks public accountability because it's a private sector entity.
We certainly want to do some hard looking at that the Medavie contract that the government didn't take the opportunity to do when they should have this last round. Because our extramural services are actually world renowned. Now, Medavie operates a nonprofit environment, and so, but it's actually, Medavie's complex. So they have a foundation, they have a nonprofit arm, they have a for-profit arm. So I'd want to look into those details to make sure that there isn't a profit being extracted from the delivery of those services. I guess our concern with Higgs and Fitch, like you said, is that they seem to be interested in promoting and advancing more private opportunities when we think we should be reducing them.
I asked Susan Holt if the Liberal Party has a credibility problem on this issue, considering their track record on privatization. Here's what she said.
I'm new to this. I'm new-ish to the party. Because I was previously a politically restricted civil servant, a private sector person, worked in nonprofits. So I haven't been a Liberal for a long time. And so I hope they'll give us a chance to demonstrate the change and the refresh that I'm bringing to the party, and the positions that we're taking and the ideas that we're exploring and the work that we're doing now. I can't go back and change the past. I can commit to how we're going to act going forward.
Merci d'être là. Je suis très heureux d'être ici avec vous ce soir à Moncton. Hier, soirée passée, je suis allé avec une beau foule à Sackville. Aussi, je pense que mardi soir, je suis allé avec une foule à Javoto. So we've had some good turnouts. Am I safe? So the tour is called Healing Our Healthcare, qui regarde notre système de soins de santé. C'est intéressant parce que depuis mon élection il y a 10 ans, les soins de santé sont l'une des deux questions persistantes que mes électeurs me posent. L'autre est le logement abordable, beaucoup des enjeux avec le logement. J'entends la même préoccupation de la part des New-Brunswickois dans tous les coins de Provence pendant les voyages de Provence. And one of the things since that time I've done, like we do as Greens in the House, is to better ensure we best understand the issues and the problems, go to the ground, sur le terrain, to speak to the people on the front lines, to speak to them about the challenges, there's the solutions they've been trying to move forward, speak to those who use the system, and we're doing this. I'm doing this on this tour as well. And I'm so grateful to all those people in the healthcare system who have given freely of their time, and we've touched more than once every section of the healthcare system: doctors, surgeons, family physicians, nurses, nurse practitioners, LPNs, paramedics, medical technologists, personal support workers, personal assistants, right through the system, you name it. So it's been very helpful, and I want to thank those who work in the healthcare system or the long-term care system who are here tonight for all of the work you have done. I know it's difficult. I think before we talk about looking forward, it's important to take a look back. because some of the decisions, political decisions that were taken in the past kind of set the table for where we are today. So it gives us some context. Au début, les années 1990 sont été marquées par d'importants coupes budgétaires qui ont entraîné la fermeture de lits. It's hard to imagine that back then beds were being cut in our hospitals, but they were significantly, which cut personnel. En 2007, nous avons assisté au début de la privatisation de la gestion de soins de santé avec l'attribution à Melody Blue Cross de contrats de gestion des services d'ambulance au Nouveau-Brunswick. C'est la première fois que le gouvernement a décidé de donner responsabilité pour la gestion d'un service de santé vers aux entreprises privées. In 2008, something fundamental happened, which was a radical structural change when we went from 8 regional health authorities to 2 regional health authorities, which represented, in the end, a significant centralization of management decision-making. And many people in the healthcare system tell me that was really where things turned. Where in our hospitals, for example, I hear from doctors and nurses that they no longer felt like they were able to function as a kind of team, a sense of being a kind of family in the hospital like they once did, because they all report up through silos to management at Vitalité or Horizon that are not in the hospital. And the hospital administrators just don't have the authority to make the kinds of decisions working with their staff that they once did. So that represented a big sea change. It's one thing to centralize administration, which makes a lot of sense, and some management decision that makes sense at that level for coordination, but to remove almost all of the management authority up into the upper echelons, the stratosphere of decision-making is proved to be problematic. 2015, public health was really decimated when Dr. Ailish Cleary was fired. The public health team that had been built up over years was disassembled and distributed to different departments. So the population health group went out of public health to social development. The environmental health group went out of public health to environment. The public health inspectors went out to public safety. So the ability, the capacity was significantly undermined at public health. And the flexibility that was there to kind of share responsibilities when things got tough was lost. In 2021, more than 100 ER doctors wrote an open letter to government. And this wasn't the first time, it's the first time so many doctors signed on that there was a major risk to patient safety unless something was done about the long wait times in the ERs. And then someone literally wrote, someone will die without change. Well, that's happened. So you gotta ask, why? Why? How did we get here? One of the things that's clear is over the years, government after government looked at healthcare not in terms of the services it was providing, not in terms of the people working in the system, but from a budgetary perspective, and saw it as simply a black hole where money disappeared. And so much of the effort was focused on trying to keep less money from falling into the black hole without heeding the warning signs that people in the system were raising about the degradation of the healthcare system. So that's part of the problem. And it sort of resulted in complacency and sometimes willful blindness to the spreading cracks in the system. And doctors and nurses and others, told me frequently that they've moved solutions forward up the chain of command to deal with specific issues, and they tend to just bounce back. not to say that some things haven't been done, but so often they represent what I would call just trying to manage the issue, doing small things with modest investments or modest expenditures that give a sense that governments are on top of the problem, they're solving those problems, when it's really just trying to keep the lid on it. So here we are in deep crisis. One of the first things we need to do is ensure that we stop using, as politicians, health as a political football. And that's been the case. When I first got elected, as it was clear that things were starting to come apart, I met with the Premier and I said, look, why don't we have a committee, a standing committee on healthcare reform, so that MLAs can stop playing games and hear from those in the system about the issues, hear about the problems, and their ideas of how to address them, what needs to be done, hear from people who use the system, what they've been experiencing. So all the MLAs together from all parties are exposed to this, and the media will cover it, and it'll be, live streamed and all the rest of it to the public. So everyone's brought along to generate a better understanding of what we're dealing with and what kinds of solutions need to be put in place. He refused. He refused to support that, and in fact, it took 2 tries. He said, well, it's political football. I said, well, this is a way to end it. But he wouldn't go for it. So let's look at some of the key areas. I want to start, there is a real crisis in primary health care. I know, I'm going to get to that quickly, but I want to start with public health, because public health really is where a lot of, outside of primary health care with family physicians, where a lot of the preventative health care and health promotion should be occurring. And that kind of prevention and health promotion always seems to take a back seat in healthcare policy. If you looked at the white paper that Dorothy Shepherd brought forward while they were consulting, I guess, on what the new strategy might be for healthcare, there was a nice chapter on this. And then when the strategy released, it was nowhere to be seen. Nothing. Nothing. It requires investment, there's no question about it. The payoff's down the road. So it's not immediate. There's no kind of immediate payoff, but there's a real payoff. So that's one of the reasons it gets ignored by the governments. There's no rapid, measurable consequence that you can point to with that investment. Il existe des déterminants sociaux, numéro 1, tels que la pauvreté, un bon défi au Nouveau-Brunswick, et par exemple les personnes sans abri. L'autre grand défi, je comprends. Ici à Moncton, maintenant il y a une augmentation des personnes sans abri par 500%. 500% depuis, you told me since when? The increase in homelessness since 2018. 2018, fivefold, oui, 500%, fivefold. Il y a aussi des déterminants environnementaux. Par exemple, le radon in people's houses. We've got, in New Brunswick, on average, 1 out of 4 homes have unacceptable levels of radon, and in some particular communities, because of the geology, it's much higher. Public health should be all over this. There should be funds for people to afford to remediate, to deal with the radon in their homes once it's identified, and that doesn't exist. Et finalement, il y a des déterminants culturels, comme le temps passé devant les écrans des médias sociaux. We know, and I met with the professionals for youth mental health in my riding in Fredericton South at Horizon, who told me, I said, what is driving all of the anxiety and depression among young people today? And they said, well, many things, but one big factor, and there's lots of scientific evidence now, which they pointed me to, that indicates this, and that is the amount of time young people spend on screens and on social media. Il y a aussi des autres déterminants culturels comme l'abus d'alcool, les fast food. So, well, we know, I think it's obvious the problems with fast food. With alcohol, there are a host of health issues around overuse of alcohol that are well, the science is very strong on this now. The risk, for example, of breast cancer from overconsumption of alcohol, significant. Public health, before it was taken apart, was ready. They just published their sort of education piece on this. It's excellent, and we're ready to launch or prepare to launch a campaign, a harm reduction campaign around alcohol. That still to this day has not happened in public health. So, pour nous, comme Parti vert, notre parti transformerait la santé publique en une force très, très publique et bien financée. So we would make, and this is the key part of the solution, is that the public health be properly financed, that it be this capacity be restored to what it was, and that we ensure the medical officers of health, the chief, the deputy chief, and the regional medical officers of health feel confident that they have the independence to speak publicly to their patients, their populations, the communities they're responsible for. And we've lost that since Dr. Cleary was fired. There's kind of a chill that happened, and that seems to be carrying on to this day. So we can do this. The results are not immediate, but if we want a healthier population, we need to do it. You hear people talk about, in the system, talk about the healthcare system is mostly focused on sick care, and we need more focus on healthcare, and that's what primary family physicians can do, that's what public health can do. So primary care, what to do? Les soins collaboratifs et les soins en équipe multidisciplinaire sont la solution pour s'assurer que tout le monde est rattaché à un fournisseur de soins de santé. Since 2003, January in fact, when a major report was published by the Department of Health on how to solve the waiting list for people who didn't have a family doctor or nurse practitioner, 2003, it described the solution as moving away from physicians working in solo practices and to a system of collaborative care, multidisciplinary health teams, a combination of those built into family practices and built into community health centers, depending on whether you're talking about a more urban area or a more rural area. Now we're 20 years later. That was the time of Bernard Lord, and the Minister of Health was Elisabeth Robichaud. 20 years later, and we've seen very, very slow progress in this area and very long waiting lists for family doctors and nurse practitioners. We're at, I think, 70,000 now province-wide, and the current president of the Medical Society said the other day, if we don't do something significant, it's going to be 100% in the not too distant future, or sorry, 100,000 in the not too distant future. So, what do we need? There's two things, really. One is a financing model, a financial mechanism, financing mechanism, so that other healthcare professionals can work in family practices in collaboration with physicians, so that they can be compensated. Right now, really the only main way of doing that is for the revenue from the family practice be used, some of that, to cover the costs of having those other health professionals involved. But you can't develop a sustainable multidisciplinary family practice team based on that. Nurse practitioners need to be able to essentially have a financing mechanism to compensate them for their work. It's not dependent on the revenue brought in by the family practice. So that's a key one. And the other is a strong commitment to roll out community health centers, particularly in rural New Brunswick, where again you can establish multidisciplinary teams. There are good examples of this. There's good models to look at around the province. I've already seen some of them. St. John is a collaborative system with a community health center hub and satellite community health centers in all of the what they call the priority neighborhoods, where there's higher levels of poverty. Very impressive, and all the health professionals work together through that hub and spoke system, that network. Very impressive. Similarly, community health center in Minto. It's exactly what was envisioned back in 2003, and it's working extremely well for a large catchment area, and includes an urgent care walk-in system. So we've got the track record, we've got the models. They're just not being universally rolled out and implemented. So that needs to happen, and that takes money, and that takes commitment. The other night at in Urshabukto, a physician got up and said, this requires the kind of restructuring that needs to be done, the kind of changes that need to be put in place, the kind of financing that needs to be put in place represents a generational investment. A generational investment to really get us out of the muck here. So I think that was quite telling, quite telling. If we had this system, then it would be much easier for those multidisciplinary teams to carry larger patient loads, and you would have far fewer people unattached as patients. Depuis mon élection sur la question de soins urgence, emergency care, depuis mon élection il y a près de 10 ans, les chefs de services des agences ont mis en garde contre les problèmes de nos services d'urgence. Les médecins urgentistes ont publié des lettres ouvertes et accordé des entretiens aux médias afin de rallier le public à la recherche de solutions. One of the things that different ER chiefs, physicians who are in charge of the ERs, have told me, it's a very short term. It's kind of a band-aid solution, but there's such a crisis right now to move patients that are being admitted who are in the ER, and there's no beds readily available for them, and therefore are taking up exam rooms, taking up monitoring equipment, and keeping the waiting time long out in the waiting room. There needs to be some kind of temporary ward where those patients can be moved out of the exam rooms in the ER, where they can free up that equipment while they're waiting for beds in the hospital. Now, yes, as regularly is said, there's no question that more beds could be freed up quickly, and there's some progress on this if those people who are forced to live, seniors who are forced to live in hospitals waiting for a nursing home space, had an actual place to go to once they were discharged, rather than having to live in a hospital, which is not any, you don't want to live there. You don't want to live there. And I mean, there's no stimulus, you're jammed in a room with a lot of other people are dying in those rooms, it's just not good. And people deteriorate significantly. So there's three things here. Number one, physicians and nurses who work around those people say numbers of them could go home if we had a home care system that was sufficiently robust to ensure that they could get the care they actually need on the days and around the hours that are required. But that's not currently available. So they're waiting for nursing homes or special care homes. More could go into special care homes, which have a fair number of vacant beds, if special care homes were financed in an equitable manner to nursing homes. That's not the case, so special care homes end up charging extra. They call it an upcharge, which makes them unaffordable for many seniors who are waiting in hospitals to go to long-term care. So we need to see more equitable financing between special care homes and nursing homes. And then nursing homes. We've got to put the money into staffing nursing homes properly. It really is that. Everyone I talk to in the system tells me that. The former chair of the Nursing Home Association tells me that. It really does come down, I mean there are other issues, but it does come down to putting the money into staffing the homes properly. And just like in the healthcare system, where all those healthcare professionals and staff are, through sheer force of will, are trying to hold everything together from falling apart, that's what's happening in our nursing homes as well. So that needs to stop. We need to properly fund them. So these two things are interconnected, and we're going to have to address both at the same time. One of the issues is also the competition that goes on between Nova Scotia PEI and New Brunswick, particularly for nurses. Donc, nous devons être compétitifs par rapport aux provinces maritimes en matière de salaire, d'avantages sociaux, et de primes. In fact, with respect to bonuses, what we've been saying lately as a caucus is that surplus that has to be spent by the end of March, otherwise it's going to go on the debt, should be paid out in retention bonuses to those working in the healthcare and long-term care systems. That would be such a huge boost to morale and might mark the beginning of a way back from the precipice. So I think it would make a huge impact, because one of the things I keep hearing from people in the system, doesn't matter what their role is the lack of respect that they feel. I was at a whatever they call it, the Association for Family Physicians in New Brunswick a couple of months back. They invited each of the leaders to come and talk about their vision for healthcare in the province. And after we had all finished, I think Premier Higgs was maybe the last to go, a family physician got up and said, "I just want to tell you, Premier, that as a physician, in my entire career, I have never felt so disrespected in my career." The place exploded in applause. I've heard the same thing from nurses, from those who work in nursing homes, from just every corner of the healthcare system. That's where we've got to, and we've got to go get away from there, which is why I say really the way back, in fact, begins with respect. Building a relationship, rebuilding the relationship, rather than looking at it as from a government perspective, looking at it as just a transactional business where government sends money and services are supposed to be provided. Looking through that lens at all those people who work in the system, the healthcare system, long-term care system, and those who they serve, has got us to where we are today. I think that, and there's more to be said on compensation. The New Brunswick Medical Society and the Brunswick Nurses Union have put out lots of good ideas about things that could be done to improve the situation, and you can easily find those online, so I'm not going to speak to them. But I do want to talk about management. So I don't know how, when it comes to a hospital, how you can manage what goes on in those walls without having some lateral authority to work across the departmental lines inside the hospital in an effective way with all departments, with nurses, doctors, and the technicians and the rest in the hospital. That silo system is real and needs to change. So we need to find a better balance. It's gone way too far one direction in terms of centralization of management. And I know this is kind of a policy wonky thing, because no one wants to talk about management, but really part of the problem is the way we've been, the management infrastructure that exists today has not been working. So we need to build some decentralization into management so that some authority rests at the more local level that currently isn't there, where it makes the most sense, rather than it largely being invested in either the regional health authorities at the top. And I'll give you an example. In St. John, the manager for primary care and the community health centers there, through sheer force of will and grit, built this system of satellite community health centers within the city and in the priority neighborhoods, they call them, around the hub of a community health center. She did that. Susan Neal is her name. Incredibly impressive. And she just figured out how to work the system. As any of you in the system know, if you can figure out how to work the system and you have the courage to push forward and the creativity to kind of make sure that you work around or go to those you need to talk to when you really have to get what you want to do. She had a nurse practitioner's clinic that the Department of Health, the Minister of Health, had announced and was set up. It wasn't actually serving really its purpose. So she flipped it into a community health center. And one of the nurse practitioners was going off, I think, to teach at the Faculty of Nursing at UNB. And so she thought, wow. They had a lot of, in that neighborhood, they had a lot of people with addictions and who were on opioid replacement program and so on and so forth. She said, we need a pharmacist. So she replaced that nurse practitioner's position with a pharmacist, and then recruited a physician, a fee-for-service physician, to work inside the community health center as her rapid access doctor. I love it, rapid access. What does that do to the patients? You mean we can get rapid access? So this now is serving a lot of unattached patients in that community that really didn't have good options before that in the past. Impressive. And she's taken the same approach to some of the other satellite community health centers. But it takes a special kind of person to do that. And we shouldn't have to rely on that to improve our healthcare system and to decentralize that kind of decision making. But I want to tell you how special what she's done is. We're leaving the meeting and the tour from that community health center, and we were in the foyer putting on our coats outside the door to go outdoors before it got really warm. And this woman, Mary, who was the receptionist, came running out. And she said, Mr. Kuhn, I've got to tell you, I just don't want you to leave before I can tell you what is happening here compared to before is magic. What kind of a review is that? When the receptionist wants to tell you and not let you go that what's happening there really is big. Big for the people they serve. That was incredible. And she was just glowing. That's what we need in our healthcare system. Having the receptionists feeling so good about the system, how they're being able to serve their patients. And that's because of the decisions made locally, creatively, and in ways that were really patient-centered, despite what the Department of Health sort of idea was for, the nurse practitioner's clinic and so on and so forth. Really impressive. So that's the kind of thing you can get with more localized decision-making. I'm not talking about flipping the whole thing over, but a better balance. Because physicians tell me that the management centrally, for example, with our trauma system has made a huge difference in responding to traumas, serious traumas in the province. Great. We need to keep that at that level, but for some things it needs to move down to the local level. So local management authority is going to be important. Finally, at the beginning I talked about one of the early moves towards privatization, or the privatization of management, which was with Medavie Blue Cross taking the contract for ambulance New Brunswick. That's been accelerating at an incredible rate. It seems like every time you turn around, you see another part of healthcare management being privatized. So we've got extramural, Brunswick went to Medavie Blue Cross. MB HealthLink, which is the new waiting list that is designed to give you access to primary health care while you're on the waiting list, it went to Medavie Medavie Blue Cross. 811 is run by a private company. We've got eVisit New Brunswick, which is run by Maple. We've got travel nurses now who are managed by and delivered by private companies. This is causing a significant increase in the costs for delivering healthcare. It's creating more silos, so the kind of seamlessness of our healthcare system that we really need for it all to work is being broken up and fragmented by the privatized management of all of these services. One of the things I learned on the tour so far is that increasingly, plus en plus, the infirmières d'agence, the travel nurses, are not coming from outside like they were during the height of COVID, but they're being recruited by companies in New Brunswick, recruiting New Brunswick nurses in New Brunswick away from their jobs, and then putting them back in the hospitals or nursing homes at 4 times the cost. Like, how does that even make sense? It makes sense when government after government has been unwilling to spend the money to ensure that we're being competitive on salary, that we're providing reasonable bonuses, that we respect our healthcare workers, and that their working conditions are sound. So this is a big issue, and it seems to be growing like topsy. As I said, there are solutions right here in New Brunswick. I've seen many. The Addictions and Rehab Center in Campbellton, the new one, really impressive. Staff, as usual, our staff in our healthcare system are extraordinary, so committed, same in our long-term care system, so committed to their work that, you know, I am just energized every time I meet folks who are showing me what's going on in their area. I mentioned local clinics in St. John with the rapid access physician. The midwifery clinic in Fredericton, a pilot project. 8 years, a pilot project. There was the government commissioned a study. So the midwives are well known for providing great prenatal care, postnatal care, and of course delivering babies in the hospitals and for those who are looking for at-home births. I had a role to play in this because back when Victor Boudreau was Minister of Health, the Liberals had committed to slowly introducing midwives into the healthcare system. I happened to be meeting with him about something else, and I said, so what about the midwives? Where are they? Because I'd been at a meeting the night before in Fredericton at the Chalmers, and the chief of obstetrics said, this kind of rhetorical question she asked, where are the midwives? We are drowning here with high-risk pregnancies. We need midwives to take a good number of these low-risk pregnancies off of our hands. Where are they? Government told us they were going to bring midwives into the system. Where are they? So I happened to be meeting Boudreau the next day about other things, but I asked him, where are the midwives? And he said, well, we were going to put them in Moncton, but they don't want them in Moncton. I said, well, I happened to be at this meeting with the chief of obstetrics yesterday. She wants them. She said, she does? Yeah. Well, that's where they ended up in Fredericton. Timing is everything. In politics, I guess. But the point is that they've been there for 8 years. Government did what they do. They evaluated the work of the midwives. And the company, or whoever, the consultants, made serious recommendations and didn't release the report. We got the report. Megan Mitten got the report from another way. And it was, the results were great. I said, you know, on all these factors, all these indicators, great results, very successful, very effective, prenatal, postnatal, birthing, and this should be ended as a pilot project, made permanent and introduced into other regions of the province. The government would not release that report. Pilot project in near Port Elgin, I think, community health center inside a school. It's working very well, very well. But you know, it's been a pilot project for quite a while. So we need to get beyond pilot projects and actually taking what we've learned, where it's working, and implement them across the province. Again, it takes money, but I'm on board. Generational investment, if it's going to fix the healthcare system and serve people better, let's do it. We've missed an opportunity with the $2 billion plus of surpluses the last couple of years, no question about it. But let's go with what the Premier says. That means we can afford to do more things. Let's do those things. Because we can heal our healthcare system. We've got to heal healthcare because literally our lives depend on it. So you just need to help me in the next election to do that. Thank you, merci beaucoup. So, il y a des questions, commentaires, questions, thoughts, ideas? Do you want to say a word?
Do you have a time sheet?
You're gonna run the mic.
Is it working?
I guess there's something wrong with the mic.
Oh,
Yeah,
I'll-
check. Yeah, no, that's not working.
We can just, I can pass it.
then you have to bring it back to me.
Yeah.
Yep.
Okay.
So if anyone has questions for David, you can raise your hand and I'll bring the microphone to you. And then I'll take it to him.
Get your steps in.
Thanks for that. There are doctors who are waiting for patients from the waiting list, but there's such a backlog of patients being transferred to the now defunct Patient Connect, moving them over to MD HealthLink. So I know, for example, Evolution Medical Clinic has been waiting 3 weeks for a list of patients that they could service. And in the meantime, you know, a family reached out to me and their little girl, 3 years old, passed away, and they're just begging because they have a little girl 5. They're like, we have to find health care for our daughter. She's all we have left. And so I know Evolution said we'd love to help more families, but we're kind of stuck in a pickle here because we need to get the names from the list. So do you know of anything that's being done to speed that process up?
Thanks. So I'm digging into it. We're digging into it because I have exactly the same question. How are those names moving out of MD HealthLink to primary care providers who have room and spaces? It's unclear. Is there some kind of triage going on? What does that look like? So yeah, I don't know, and we're going to find out. But it's important to understand how that's all working at this point. Absolutely. Yeah.
Do that.
Page disappeared, but here it is. This is an important statement for me to make, and also some questions that are important to me. So I've put it in writing, and I hope I can have audience contact while I'm mostly reading it, because the words are important to get it right. So good evening, Mr. Kuhn, and good evening, community members here, healthcare workers, whomever would be here. Thank you for putting on an event of such an urgent topic, healing our healthcare. My name is Robert McKay, and I'm associated with a few organizations, but tonight I am speaking as an individual for myself on behalf of a small band of what you might call misfits. Tonight I wish to put on the record that there exists a potential large-scale workforce solution that could make a significant improvement in various areas of healthcare in New Brunswick. During a period of a few years around the turn of the millennium, the province almost funded a group of other misfits who could have helped build a certified peer support workforce in our mental health system at the time. Such a workforce, I believe, based on facts that I've seen in places across the world, especially the United States, could make an inspirational impact on our homeless problem that we experience today through recruiting people in recovery from homelessness to be an extraordinary healthcare mentor to bring their peers out of the mess that they might be in. I left New Brunswick for Ontario in 2005 and I stayed for 12 years. From Toronto, I was lucky enough to see incredible things across Canada and from people who came to Toronto from across the world. And more particularly, I saw just incredible large-scale workforces in the United States. Particularly, I was in Georgia and Michigan, and people said these large-scale workforces saved their lives. I have to double-check my research, but I think that there may be some awareness in the Greek Party of New Brunswick of the Certified Peer Support Specialist Workforce Solution. I'm going to check on that unless you're aware of it. My questions are two, and then I'll have a final statement. So, are you aware of the existence of such workforces, number one? Two, would you help me to help you to connect with some experts who have revolutionized healthcare, mental health care in particular, in many parts of the world? Would you help me do that? Through the fastest growing new workforces in the state mental health systems all across the United States, the certified peer support workforces. If you would do that, that would be such a beautiful symmetry of the work of people 20, 25 years ago who tried and kind of failed to get there at the time, but didn't give up. It would be that beautiful symmetry that would honor those misfits of the time. And we would show you a group of current provincial misfits today who are available and willing, who could help us make some of the transformational scale changes that we say we want to do, and with profound and inspirational impacts on New Brunswick citizens, taxpayers, and healthcare patients. If you need me to say the questions over again, I will. But thank you for being here. Are you aware of the existence of such workforce?
No, I'm not familiar with it, but I'd be really interested in learning about it. To know about it, it sounds, what you're talking about, it sounds like really quite promising, but I'd like to learn. So maybe you can help me learn about it and see what we can do around that.
So you've really answered my second question, which was, would you help me? So I have very specific people in the United States that I would love for you to connect with, and so I'll follow through to help you do that. These are global experts in this workforce.
I'd be interested. I'm easy to find, so.
You are. You know where you live.
That's
Thank
right.
you, David.
It's important to try and be on top of things that are really making a difference. Today I learned about nursing homes without walls at the nursing home in Port Elgin, where it's in that community is being utilized. Not the only one, but it was one of the early ones that adopted it. Suzanne Blanchard, I think University of Moncton, kind of initiated it. And wow, was that impressive. Is that impressive? They've got 550 seniors in the Port Elgin-ish area who are part of that. There's a couple of staff. They just hired their first personal support worker to go in the homes. And it is making changes in the lives of those seniors. Like, it sounds so impressive. And I heard the name, like I've heard the name of what this gentleman was just talking about too, but I didn't know anything about it. Today I learned, and so there's great things happening, and we need to know about them and make sure that we adopt those things that are going to work well here.
Thank you.
Any other questions?
Hi, I'm John Scott, I'm a retired physician. Remuneration with nursing staff and medical staff, do you think there's a case for this being federal? like rates across the country. And it probably won't happen, but you know, you get the situation where you're poaching from one place to another, or you want to make more money, you go somewhere else. I mean, you know, at some point, this becomes very counterproductive.
It's a complicated country.
Yeah.
So,
I've got a second question.
I mean,
Yeah.
on paper, wouldn't that be nice, right?
Yeah.
You can see the logic, but I can't quite imagine how it would work in a country like ours. That's for sure. But if we could get something like that, at least in our region, through agreements between New Brunswick, Nova Scotia, and Prince Edward Island, I think that would make a huge change.
One more question. I'll probably get shot for this one, but I'm going to do it anyway. Is I work with RNs, I work with BNs, and excellent people, you know, for many, many years. And the RN course is an intensive 2-year program, and the BN course takes 4 years now, and with holidays and stuff. Now, do you think a lot of people not going to nursing because they don't want to do the 4-year course? Is that an impediment to getting people to enter nursing?
Maybe. I mean, my sister-in-law did the 2-year before it changed.
Yeah.
She's an excellent nurse, not biased. She's worked in the hospital for a long time now. She's doing extramural. Her patients love her. I mean, that was a 2-year program, so she certainly didn't suffer from it. But I'm not informed about this. I don't know what advantage is from the 4-year program versus the 2-year program. So it'd be an important question to look at. No question about it. My mom's a nurse. Well, she's 91, still is a nurse. She's always a nurse. And so I've got a lot on my shoulders because she keeps saying, Dave, why haven't you fixed the healthcare system that you got elected in 2014? So she's got expectations, not just the people of the province. So Mom, you're working on it. But yeah, I mean, she would have had it, it was a bit complicated. But yeah, she would have gone through, in her time, a 2-year program, but she then also did a Bachelor of Science in Nursing, which was pretty brave, just off the farm, and succeeded. But anyway, I think that we need to look at it. I mean, I don't know. And maybe, you know, one of the things so I'm starting to get into territory that I'm speculating about here, but one of the interesting things I've heard is, so there's this move for nurses to start to specialize in the training at university, right? So you come out with a specialty in your nursing as a nurse, more and more. And maybe that becomes the 4-year, and the 2-year is the sort of general RN. I don't know, but like I'm an ideas guy, and I love people who generate ideas, and John, you're very good at generating ideas as well. They always get you thinking, and so it's that's what we need to work. That's what we need to work to inject solutions into the system that aren't apparent yet. So thank you for that suggestion.
Any more questions? Oh,
Yes, I'm the new kid on the block. I always thought the Green Party was for the environment. Tonight, it's a different story. We didn't talk about the environment that much. We talked about medical emergency. Just to say, this weekend, Sunday morning, I got a sister-in-law. She's very sick. And there's an 82-year-old brother taking care of him. And she can't walk. She can't even stand up. So that means he's got to watch her when she does it in the bed or in the chair. Anyway, it's a no on. So she was very badly sick. They brought him in the ambulance to the hospital, and they put her in not a hall, there's nothing, no. They said that you're going to stay in the hall. So am I going to go back home? So the ambulance brought her back home. Now she's home with my brother, 82 years old, If she's 81, taking care of her. It's so crazy. It's so crazy. We got millions of dollars up there. Anyway, I usually don't talk with them. I get pretty well lined up what I want to say, but I was just balling up, eh? And it's got to get something done. I mean, anyway, there's so much thing to do. So much thing to do. And we're just scratching the surface. Yeah, scratching the surface. Thank you.
We are, thank you. And, you know, I spent the last 10 years learning about everything but the environment, because I had that covered.
Yeah.
So, on the environment, we got that better than anyone else.
Yeah.
But the last 10 years, I've been drilling down into the major issues that New Brunswickers are facing beyond the environment. Learned a lot. Like I said at the outset, met a lot of amazing people who have helped teach me to understand the realities on the ground. And it's the case in other areas as well. I mean, it's, you know, whether it's homelessness, housing, education, poverty, struggles the small businesses have. So, you know, my hair's not ready to go back because my head is so full of, you know, new information from the last 10 years. You know, that's hard work and important work to inform yourself about things that are most important to the people of the province, so that you can bring forward solutions and try and get them implemented. That's why I work. And you know, one part of this is, as an MLA, and there's no handbook for being an MLA. When you get elected, there's nothing to go by. So, you know, you run and you've got an election platform and so on, and you try and see some of those things implemented, but also a good proportion of what you find you end up bringing to the legislature, and this of course is how it should be, is informed by the trials and tribulations and the problems that your constituents, and in my case as leader, other people outside of the riding come to me, that they're encountering. Because it's not only, you can help them maybe, but the same problem keeps reoccurring. You say, there's a problem in the system, and it's going to need a legislative change, it's going to need a policy change, it's going to need a different way of spending the budget, and so on. And so, and really, this is the beauty of democracy in action. This is how it should work, and it's not been working very well, but your constituents come to you with issues, and you try and help them on, you know, with this particular thing, but you need to be open to recognize that this is part of a bigger problem that they're experiencing in their own lives. It's not a one-off situation, and it's your responsibility as an MLA to figure out how to take that to the legislature, take that to a cabinet minister, and say, there is a problem in the system that is causing this problem repeatedly, and this is how you can fix it. So that's one of the reasons I love this job, because you get to help people in your community, and as leader, I help people elsewhere too. That's great. It's not always possible, but more often than not, it works out. And then you get to help bring about change in the province, so that those problems don't start or keep cropping up and keep popping up for other people. What could be a better job than that? It's the greatest job in the world, I find, for me anyways, to be able to serve that way and to learn. You know, say, okay, something's not working. How are we going to fix that? And it not working is harming the lives of people, or making their lives difficult to get by, or what have you. Let's fix it. Let's get to the bottom of that. What is causing the problem? And politics is all about, really, supposed to be about making decisions to advance the well-being of people and push the common good, the Biencommon, forward, right? That's what drives me. I love it. Some days I don't, but mostly I love it.
That
dad drives you, but there's also that mother of yours too.
Yeah, I know.
Drives you.
She's here. She's here. She's in my phone.
Hi, I'm speaking as one of the long list of people without a family doctor or nurse. I've lost 2 nurse practitioners since I've moved to Brunswick, and I don't blame them. I mean, poor nurses are overworked, underpaid, and why not take off, get paid far better, take your vacations when you're supposed to. I mean, it's a crazy system. I look at what the Premier's reaction was to the death in the Chalmers Hospital. He fires Dr. Dornan for, just as a scapegoat. There was no connection between Dr. Dornan and the death that happened there. And he also demoted Dorothy Shepherd at the same time. And the way he did it was to call in to appoint Bruce Fitch and call Dr. Dornan and put Bruce Fitch on the phone, and Bruce Fitch says, "I'm your new minister, and as you know, you serve at my pleasure." You're going immediately. And as a result, Dr. Dornan sued, and he won an arbitration award of $2 million for the remaining time on his 5-year term. And $200,000 of it was to compensate him for the damage to his reputation. Now, this is absolutely absurd. Does the Premier think he's going to attract doctors to the province when he treats people that way? Does he think that people are going to be coming to be nurses when they're being so better treated in the next province over? I mean, this is desperate. I'm not expecting to see a doctor or a nurse practitioner anytime within my lifetime, but it is very frustrating. I really worry about whether the way that provincial governments are approaching healthcare and privatizing it, whether they're not trying to destroy Medicare. That's really what, in my view, is happening.
Yes. Here.
Take note of the debate.
Hi, my name is Dan. I wanted to comment, I won't go through the whole story, but the first gentleman that spoke over here, I had the experience of having an equally frustrating situation that I worked in the penitentiaries. Then I worked for 20 years in Atlantic Canada promoting crime prevention programs. And what I want to point out is that when I retired, I've got an opportunity to work on a problem that has never been solved in the police area. I work with policemen and corrections people. And in my retirement job, I was 10 years as the president of the Family Crisis Center in Shediac, now called Courage. And that was designed, and what I want to tell you is it's designed on some of the things you've talked about. The ideas there came from I had the experience in my job being exposed to potential solutions all over Atlantic Canada. And I'll give you one example. Do you know that domestic violence cases were not even counted by the police in 1972? I know it's true. I did a personal inventory of a sampling in police departments. They were called family incidents. Okay? Now, the law has changed since then. Police are required. What I want to point out, and what drove it in my retirement, I got no money for it, okay, 10 years, was the fact that I went to, I'll tell you just where it was, to the communities between Grand Jig and Chimaway, centered in Shediac, okay? And I went to the people, and what I'm trying to make a point here, 2 points. One is like you said, like we heard tonight, the answers are out there. The answers in our case was quick response to domestic violence cases, 24 hours a day. And I went to a meeting where somebody suggested that Muriel McQueen has suggested that. And I was there just out of curiosity because I knew the area of work. And I decided that's what I was going to do with as many years as it took in my retirement. And it took 10 years and I thought I'd been successful. This is an organization, what the point is that you have to have some way that the people who are having the problem can have input. That was done through town meetings in all those communities. We had 90 people from those communities came together, and the program was planned like that. Okay? And that's what will drive the kind of change that I heard people say they wanted here. Get groups of people who are not necessarily the victims of the situation, but they understand to come together and pressure. Because you know what? Those people vote. Okay? That's the point. Okay? And we even brought some people, well, I'll give you one example. Greenhouse concept, nothing to do with environment. It has to do with the method of seniors' homes. No more than 10 people, groups of 5. I met with the director, the guy that wrote the books, and he came up and spoke here. You know the answer we got from the politicians? That's an American program. We won't do that. I don't care where the answers come from. I want to see answers. And I do that in my personal life too, in my family life. And the answers are there. We just have to pursue them very aggressively. And the best way is to pursue them is with coming directly from the people. I could go on, transparency, management through transparency, community support. In case you don't know it, the organization in Shadiac was primarily 90% supported by community money. We got great cooperation from the people working in the justice system. In fact, the director there for 4 years had a salary, half coming from the government, half coming from the community. Okay, she was on loan to us she was a court-based, the problem was the province didn't have money to start 24-hour-a-day services all over New Brunswick. They still don't. And one of those models was started in Restigouche County from Kedgwick to Grand Dig in '78. And I was never able to get it accepted as something you could do. Okay? And when I retired, I said, it's going to go. It took me 10 years. We had 6 employees when I left 10 years ago. And I went back to the 20th anniversary in April. They have 22 employees. A good portion of those employees' salaries, not others, but the salaries, are paid by people in the community, by their donations to that organization. Now, you'll never see that happen with healthcare. But the part of having participation of people in their communities in what happens is a big part of making change. Thanks.
Thanks, Dan. Did you want a response to that?
Sure. I want to know how we can do that, how we can organize. I don't know if you can go as far as we did in Shadiac, where we had 2 and 3 people from each of the communities, if you don't, from Chimaway to up to Rondig. And out of that came a board of 18 that managed the program. And I saw myself as a servant of the program. I didn't lead it. All I did was show them a management practice, how they could operate in a way that they could clearly identify. It came from actually Health Canada, setting objectives, setting goals, setting responsibility people. Okay, and that's the way it was done. With people we started with a meeting of 90 people in the church basement in Capolais. And we had 18 board members. There's only 1 left on the board now. I'm really happy about it. You know why? The 1 person left on the board happens to be a woman. I thought whether I could start it, I would have preferred to see all women managing that problem. They weren't. They are now.
So I think one of the things is today, lots of communities don't have that kind of social capacity to organize the way you're talking about. There's a real role to support communities to effectively organize. Yeah. And so I want to set this dream that the Memricook Institute be turned into a training center for community development.
Yeah.
I think the core ideas that you're talking about, it's probably going to be a small core and get some training and learn about how to build that out and engage more people effectively to get to creating the kind of thing that you were involved in creating. That would be tremendous if we had that. And, for generating income, it could also train municipal politicians when they get elected, perhaps, to counsel it for the first time to understand the ropes. Anyway, I just see the need in so many places around the province where there's great initiatives that people are undertaking, but they today just don't have the numbers of people to work with them. So if we had that kind of, animateurs, I guess, so people who can animate this at the community level. Let's involve our universities and connect them all to what I imagine would be the Memory Center. What a great location for it. And why I say Memory Center for one of the reasons. I went to a training thing there years ago, and this is a fantastic space for so many reasons. Fantastic location, and let's turn it into something that can help our communities.
You had some of the answers. You gave examples. Why can't we have a demonstration project in all those places where it's already started? I'll guarantee I'm 81 years old. I guarantee my next 10 years we will in one location.
We'll hold you to it then.
No, but you mentioned the examples that could make change. But if you have a number of them being transparent to everybody in the province, it would mean votes.
Yeah.
And that's what will change it. Sorry.
I'm curious about the schools that serve the professionals in the medical professions. Are they producing sufficient graduates to serve the needs of the province, or are there just too few chairs and too few people interested in the vocations?
Well, maybe the physicians in the room could speak to that, because on that side, I don't know. John talked about concern about nursing being less attractive today than it was, and raised a potential reason. What about physicians, John? Or Susie?
Well, certainly, I came here in '83. I think everybody had a family doctor back then. I think I'm right in saying that. And people were selling their medical practices for cash for the patients, when they retired. And we now have a situation where we've got people who don't have a primary healthcare worker, personal physician.
Sorry, I can't hear you.
So I'm sorry, we have a situation, I came here in '83, everybody had a family doctor. It's now we have a whole bunch of people who don't have a family doctor, okay? And we actually have more family doctors than we had back then. Now the population has grown somewhat, but that's a question we kind of have to answer with more people.
Maybe answer a little bit. So, I'm not going to mention any names, but I know a physician who has students in his practice, family physician. And this is what he told me, that they're either going as hospitalists or they're taking over existing practices. So,
Yeah, that is an issue too. I met with medical students a while back, and Brunswick medical students, I asked them, what are your plans? None of them wanted to be, none of them were planning to be a GP, a family physician. None of them, not a one. These were really young medical students, eager to launch their careers in the next couple of years, and not a one.
Well, could government do something to encourage that, give them some incentive to become family physicians and stay here, like help to reduce the debt that they accumulate?
So, yes, I mean, there are those kinds of things that can be done, but the work of a family physician, a general practitioner, is I mean, there's so many things they have to know and be responsible for. There was a commentary written by a family physician in the Globe and Mail last Saturday, or maybe the Saturday before. I don't know if anyone saw it, but I've got it. I printed it out because it was so informative about the workload of a family physician, the multitude of things they have to deal with. And it's very diverse work, obviously, of course, because they're general practitioners, and the compensation and all of that goes with it. as issues, and she became a hospitalist. She just had to get out. She was burnt and couldn't continue. But so there is something there about, and she said, you know, the complexity of people's health, the gravity of health issues, the variety of chronic diseases, all these things have increased compared to the past for families and physicians to manage. It's hard to carry the same patient load as doctors did in the 1970s as today, because what they call the acuity, I guess, the patient's acuity, the amount of the seriousness or the complexity of their health condition is much greater in many cases, or more people. So that seems to be part of it as well, that's going on. But yeah, I mean, that's something to really drill down into. But if you get a chance to read this story, and I got to go back and reread it, because it really, for me, shone a light on the reality of general practitioners, family physicians. When I read it, I thought, no wonder no one wants to go into that anymore. That is one heck of a lot of work, and you don't have a life. So anyway, that was one doctor, you know, with her opinion, but that was her experience, and it was pretty informative.
Try to be real brief. I just want to speak again because of this gentleman here, what he said, the common sense, that the frustration that you said that you experienced, and boy, we must be related or something. A colleague of mine way back when saw me in a media report at a midwifery conference that was being held at what was then the Mountain Lions Community Center or what have you. And he said, what the hell were you doing at a midwifery conference? You know, it's all about peer support and stuff. And the gentleman here closing the loop on this, and it's a lesson that I want to just reinforce. He talked about the Beausejour Crisis Center and midwifery. Well, no, not midwifery, but I'm tying the ideas together. So women, a group that are traditionally marginalized or you know, undervalued and what have you. What they found in midwifery and also in crisis support with people who've been through the mill themselves is that these people are healthcare workers by virtue of the lived experience that they have as human beings. They've had babies. They're smart people. They've learned some formal stuff around that. People who get beat to crap by intimate partners, they know the ins and outs of that better than any person, healthcare worker, can learn from a book. They know it. And they are healthcare workers when they are counseling and supporting their friends, crying on their shoulders, helping to get them out of it. And going to who's the worst marginalized people traditionally in the world is mental patients. And so the miracle of what I've seen in the United States in particular is that finally a realization happened in a big way in Georgia when Medicaid started to bill for services, and they've hired thousands of people in Georgia alone, thousands of these workers in Michigan. And I've been to both of those states. And the lived, you know, so the comment that you made about the people themselves need input, true. But not only that, in a healthcare crisis situation, a selection of those people who could give you input are also healthcare workers themselves that can take the burden off the system. And I can only dream, but we have peer supported in Brunswick in different pockets, bits and pieces. I believe that we could lead Canada if we saw the big picture and did a scale size workforce. So that's my 2 cents. And thank you. Thank you. Don't run away. I want to meet you. Thank you.
Kept it long enough, I think. I'll stick around if people have further questions and want to chat. But merci beaucoup d'être là. Vous êtes été très patient. Je vous en prie. Thank you very much. Bonne soirée. Have a great evening.